Hey guys, I know most of you know me, but for those of you that don't, my name is Angel McClellan, and I'm an LPN going back to school at Hocking College to get my RN degree. Amy was gracious enough to let me come here today to talk to you guys a little bit about this superbug that we're dealing with called MRSA. A common misconception about MRSA is that it's limited to immune-compromised patients in a hospital setting, and that is simply not true anymore. It can affect anybody at any time, including healthy patients, but your clients in this facility are at an extreme risk because they may be immune compromised and they're in a facility where they're in close contact with other individuals. According to the MRSA Research Center at the University of Chicago Medicine, MRSA kills more people in a year than AIDS does. Over the last 7 years, I've attended many in-services about MRSA, and I've treated a lot of MRSA infections, ranging from minor skin infections to major wounds and respiratory infections. I believe it's important for direct care staff to be aware of the signs and symptoms of a MRSA infection, the treatment options available, and any side effects or adverse reactions that are possible from taking the medications that will be given to treat a MRSA infection. First, I'm going to talk about what MRSA is and the two types that they have identified, hospital-acquired and community-acquired. How it's going to look when you guys see it. And I've got a handout that can give you guys an idea of what it's going to look like. And then I'm going to talk about the common treatments that are prescribed for MRSA and any kind of side effects or adverse reactions that you guys might be dealing with while the clients are in your facility. Now, can anybody here tell me what MRSA stands for? MRSA stands for methicillin-resistant Staphylococcus aureus, and it's a strain of staph that's resistant to the penicillin line of antibiotics and also cephalosporins. The resistance was caused by misuse and overuse of antibiotics when they were first invented. MRSA was first diagnosed by the British in 1961, but the first United States case was found in 1968. So in the last 40 years, it's gone from a small isolated problem to a huge problem. It's being tracked by the Center for Disease Control, the National Institute on Allergy and Infectious Disease, and medical centers and universities worldwide. According to the National Institute for Allergy and Infectious Disease, 57% of hospital-acquired infections are MRSA. That's a pretty alarming statistic, if you ask me. It began mainly as a hospital-acquired infection associated with IVs, ventilators, surgical wounds, but they have, since the 90s, found a strain of MRSA that is acquired in the community that is very contagious, way more contagious than the hospital-acquired strain. It typically presents as a skin or a soft tissue infection that people commonly mistake for an infected bug bite or spider bite. And the first thing that the doctor's going to ask someone in the ER that complains of a spider bite, he's going to ask you, did you see the spider? Because chances are it's not a spider bite. A small infection like that can very easily and quickly become very invasive and life-threatening if not treated. It's prevalent in schools, jails, gyms, child care facilities, long-term care facilities, and any other place where you have people in close contact like they are here. It's very contagious, like I said, and it's spread through direct and indirect contact, so skin-to-skin contact, and by the indirect mean of sharing towels, razors, or touching tables, sports equipment, toys, or specific to this environment, adaptive equipment. And this is where you guys come in. Direct care staff may be the first to see a new community-acquired MRSA skin infection, and you play a big role in the prevention of the transmission of infection in an undiagnosed case of MRSA. So here's what you're going to be looking for. I have a handout to pass around so you all can get a good idea of what MRSA skin infections look like. Community-acquired MRSA is going to look like these pictures. It's going to look like a little bug bite, or it could look like a cluster of bug bites, and they're going to be white or yellow in the center. The tissue around it is going to be red and inflamed and hot to the touch, or at least warmer than the surrounding skin. And it's going to be very painful. Your clients, as you well know, may not be able to bring your attention to any new skin lesions that they have, or let you know that they have a painful area. So it's very important that you know what to look for, especially during times of personal hygiene and care. The common treatments that you're going to see ordered by a physician for the treatment of a MRSA infection are going to be dependent on the location of the wound, whether or not it's draining, and if there's the presence of any additional signs and symptoms such as fever, shortness of breath, increased heart rate, chills, which all may indicate that this patient is becoming septic. Some medications you're going to see used are going to be clindamycin, doxycycline, minocycline, Bactrim DS, that's a very common one, rifampin, and linezolid. Linezolid is pretty expensive, so it's one of the last ones that they're going to order though. The preferred hospital given by IV, or the preferred hospital antibiotic given by IV is vancomycin. In the hospital setting, allergic reactions tend to pop up a little bit faster because they're getting that medication directly into their bloodstream via the IV. When they're in the community setting or at home, the allergic reaction may take a day or so before it's going to pop up because it takes a little bit longer for these medications to go through the GI tract and cause a problem. So you guys may be the first ones to catch this reaction to this medication, so you need to know what to look for. The symptoms of an allergic reaction are going to be any kind of a new rash, hives, a swollen face or tongue or throat or any other area, a fever, or even increased seizure activity. If you see any of these signs or symptoms, you need to tell your nurse as soon as possible because it can very quickly become deadly for this client. Antibiotics that they're going to be getting can also interact with other medications that they're already on. It can definitely interact with their seizure medications, which I know many of your clients are on, but it can also react with diabetes medications, anxiety medications, depression medications, high blood pressure medications, heart medications, steroids, the list goes on and on. There's a ton of interactions with these medications. So you definitely need to keep your eyes out open for something new that's going on. You need to also be looking for any kind of a mucousy or watery diarrhea in these clients while providing care for them. It could signal the presence of C. diff, which is very commonly caused by these stronger antibiotics that are prescribed for this MRSA infection. When people get diarrhea, the first thing they typically want to do is take Imodium or some kind of anti-motility drug to basically stop the diarrhea. And when you do that in a case of C. diff, it could be very detrimental to the client. So you want to make sure you're reporting this to the nurse so that it can be investigated. Community-acquired MRSA is treatable by more antibiotics than the hospital-acquired strain, which is great, so they can be treated at home a lot more readily and easily. But these strains are mutating every day, so they can become resistant to these antibiotics even still. And that could cause the infection to spread as far as even to the blood and cause this patient to become septic. If this happens, what's going to happen is they're going to end up going into the hospital and receiving IV antibiotics like Vanco, like I told you before. The problem with that is, since 2002, there have been several cases reported of vancomycin-resistant staph, and it's got doctors and specialists really worried that a day here soon we're going to be out of antibiotics to treat staph altogether. The doctor may also need to do an IND procedure on the client's abscess, which means incision and drainage, to get any kind of pus or infection out of the wound, and that's going to require a daily dressing change. And where you come in on that is we need to be monitoring the dressing to make sure it's clean, dry, intact, and to try and prevent the transmission of the infection to any other clients or to yourself. You can also prevent the spread of transmission by making sure you're wiping down any surfaces that the client touches, any adaptive equipment, computers, chairs, tables, wheelchairs, anything that they may come in contact that you may also come in contact with or another client may come in contact with. You can wipe those down with any kind of wipes that are approved to kill the MRSA bacteria. Now, can anybody tell me the #1 way to prevent the spread of infection? It's hand hygiene. Good hand hygiene. You need to be washing your hands all the time. Wash your hands, wash your hands, wash your hands. So today I talked a little bit about what MRSA is and the 2 kinds that are out there, the signs and symptoms that you need to be looking for, what it's going to look like, and the ways that the doctor are going to treat this, and what your role is in those treatments. And I also kind of touched on what side effects and adverse reactions you could possibly come across so that you can be aware of what you need to report to your nurse. I think we can agree that MRSA, both healthcare acquired and community acquired, is becoming a huge issue and has been a main focus of research for over 40 years. This smart bug is only getting smarter. Each year, 90,000 Americans suffer or are affected by a MRSA infection, and of those 90,000, 20,000 of those patients die. The need to educate direct care staff on the prevalence in the community and the signs and symptoms and reactions regarding not only the infection itself, but the treatments associated with the MRSA infection is imperative. So I'd like to thank you guys for letting me come out and talk to you a little bit today, and I hope that you all feel like you learned something.